All right, Dr. Graypel, thank you for being with me this morning on this wonderful sunshiny, I can't say that word today, day here in St. Louis. Um, would you be willing to share your journey from your medical training abroad to really establishing community long-term psychiatry in St. Louis? What was that journey like?
Do you really want to know? We have only half hour. We don't have like 3 hours for me talking
I
about
know
myself.
you've got like 10 minutes. So mentally prepare for that 10 minutes and then we'll go to 20.
Got it. Okay, well, that's actually simple. I was originally trained in Soviet Union, former Soviet Union, in
Yep.
internal medicine. I've done a lot of internal medicine, cardiology, GI. I was teaching in medical school over there. Came over here, had to, as you probably know, had to start all over. Came in with no English, had to just do everything and whatever. And since I was not licensed in the United States, and I had two kids, I had family, I couldn't even just sit down and just study for my boards. I had to do something. I went to business. I established home healthcare company. Then I established, then I bought my first assisted living facility. So I ended up being licensed nursing home administrator, working in long-term care industry, and owning two offices of home health care here in Owensville, Missouri,
Mhm.
and having three assisted living facilities, which I run by myself. Two of
That's
them.
wait. Hold on. All that all at one time and you're still alive.
I am.
Yeah.
Believe it or not.
Yeah, that's a lot.
I mean, I had no choice. I had to survive. But
That's right.
but it gave me a lot of experiences in different aspects. Well, I always kind of was minded person,
Yeah,
but
yeah, yeah.
in a fairly decent physician, I think. But it just gave me a whole bunch of different experiences in whatever. Then I said, well, I'm not getting younger. I
Sure.
have to do something with my life, and then I sold all my facilities. And while I was still managing my home health, being administrator and manager, I passed all my tests, and I was lucky enough to get into psychiatry residency. That pretty much.
Well, what was that inspiration though? What was the like I want to go into psychiatry for to make that transport? What was it just like you said I'm not getting any younger. What was it? Was it the physical nature? Was it the stress? Was it the what was that I got to switch?
See, I was actually doing okay, finances wise. As I said, I was always business-minded person, and
Right.
I think I was okay in the business, and I was making decent living and whatever. But big part of me was kind of missing. This
Mm.
being a physician, being a clinician, being making different kind of impact in people's life.
Yeah, making that change, right? Yeah.
Pretty much. So
Yeah.
that's pretty much what I was doing, and why I decided to okay, now enough is enough. When my son finished, my oldest one finished school, I said okay, now it's time for myself, and that pretty much no youngest one, whatever, one of them. Yeah,
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 because you're a family guy. So we take what you do, Papa Bear. So we take care of family first, then we can take care of us.
that's pretty much what happened. That's what I was
That's it.
doing for years before
Love.
before I became licensed physician.
Nice. Now, your clinic offers a wide range of services for anxiety, depression, PTSD, cognitive disorders. Can you elaborate on some of these services and really what makes your clinic different from others? What's the secret sauce to all this?
Well, I hate to say that bluntly, but it's me.
Good, as it should be.
Well, that's true to some degree, but here's the thing: I never allowed myself, and this is part of that has been my former training in the Soviet Union. I was never allowed to treat a diagnosis without going to the root of the problem, and or maybe it's my OCD. I don't know, but this
Sure.
is one of these two things. But I and this is how I treat my how I teach my nurse practitioners. This is how I work with my therapists. We don't treat a symptom. If we see anxiety, we need to go to figuring out why anxiety happened in the first place. how we can address this issue to work with anxiety, to eliminate anxiety. If we see depression, we need to go to figure out why people got depressed in the first place. If it's something temporary, if it's something fixable, if it's something just manageable. And that's pretty much what we do. That's what makes us different and unique to some degree. And cognitive, well, you already know, I don't know, you got a chance to read my book, but yeah, this is what I always kind of was wondering. I'm weird to some degree. I have my own ways of treating cognitive impairments.
Sure.
You know, when you probably get a lot of spam in your email. Oh,
Tons.
it's this,
A
it's this food,
100 every morning
pretty much,
at a
pretty much.
minimum.
Yeah.
Yeah.
Eat this food and depression, dementia is gone. Eat this food and you will never become whatever.
Yeah, right.
We cannot mislead people. But
Yeah.
my message and the reason for me saying, because you know, I in the hospital, when I work in a lot of hospitals and providing consulting liaison for medical teams, I'm not talking about inpatient psychiatry. I work in medical settings, in medical hospitals, and we work, and I'm talking about me, my nurse practitioners as
The
well.
team. Yeah, yeah, yeah.
Yeah, the whole
Yeah.
team, and we treat psychiatric implications of medical conditions, substance-induced anxiety or depression, medication-induced psychosis, depression, anxiety,
Yeah.
medical condition-induced depression, and whatever, and of course, delirium and whatever. So that's pretty much why I wrote this book. Mhm.
And I think it's I had some new patients this week, and one of them we got to she just had a knee replacement, and lovely patient, been treating her for years, and she's like, they drugged me up good, is what she's saying. And she's like, I got the painkillers. Well, just because I got to get through the healing process, right? Well, that brought on constipation, so they gave me something for the constipation. Well, that brought on irritable bowel, so they got me one for this. And then because I had the irritable bowel, my acid reflux flared up, so they gave me something for that. Because of that, I became depressed, so they gave me something for that. So it's all this trickle down, trickle down, trickle down. And what you're saying is the secret sauce, which should be on every physician's lips, is why is this the way that it is? Instead of just, okay, you're anxious, go smoke a cigarette. Well, you're smoking a cigarette, you smell like smoke. So just go to the dry cleaners and get your clothes washed. You won't smell like smoke. Well, now you smell like chemicals from the dry cleaners. Put a little extra Febreze. That smells like the ocean breeze, right? So it's always, what's the next step? Well, I think it's beautiful to hear that from a colleague and a physician to say, we're actually digging down into what got you here. That gives me goosebumps, gets me into the cause of the problem for these patients and actually bringing them life-changing results.
True. And that's what we do. We usually start from evaluating a medication list, and we usually see, okay, what could be causing this? What can we get rid of?
Yeah.
Less is more, and that's our motto.
Yeah. Love
To
that.
answer your question, what makes us different? That's actually our motto. Less is more, and this is what we stick to. We stick to our guns, and that's what we believe.
Okay, so I saw that you also do Spravato, which is the intranasal esketamine. Is that right? Did I say that right? Cool. So highlighted as a treatment for severe depression at the clinic. How does that work, and what is that benefit to patients versus other traditional therapies?
Let me step back.
Please.
Spravato is one method of treatments we
Okay.
employ here. But for me, I hate to be that blunt, but you already know me.
I love that. Like, let's just black and white. What where are we traveling?
To me, if all else fails, then I go to Spravato route.
Got it.
It's like if I hear, and I hate to badmouth my colleagues, but I'm gonna say it anyway, because I cannot not do that. if I hear treatment-resistant depression, my knee-jerk reaction is doctor is doing a good job on figuring things out. What was the cause? What are we treating here? Maybe it's personality disorders that they're trying to treat with medications. That's number one. And number two, why the doctor is calling treatment-resistant depression? Because reimbursement for provider is higher. So for me, that's actually what I do. That's why I utilize Spravato. It's very good method of treatment, but to me, it's last resort. If all
Makes
else
sense.
fails, and that's why you can look at my patient list. I don't see too many patients with Spravato. Why? Because we address issues properly. We treat
Love it.
personality disorders properly. We just don't get them to the point of being treatment-resistant depression.
And Doc, it's refreshing because in every industry we have those other our colleagues, right? And for me, we have other, like, we do corrective care in our practice where, like, we get to the cause of the problem, we address the problem, and that's how we fix it. And that's how patients get not results for this next 2 weeks, but they get results for the next couple of years, right? That's what it's all about, long-term correcting problems. And it's frustrating whenever our colleagues are out there saying, oh, listen, I'm just going to patch you up, come on down, let's whack and crack you, and then adios. Well, I'll see you when the pain comes back. And we know that the problem's not solved. They're just going to come back looking for that fix, and it's never the true benefit to the patient. It's only the benefit to the clinician, which in my mind creates an ethical barrier.
Absolutely.
It's not the way to do it. Now, long-term psychiatric care is a focus of the practice. What unique challenges and rewards come with providing those services in a long-term care setting? Can you break that down a little bit for me?
Yeah, so the reason I named the company is Community Long-Term Care Psychiatry, because we deal with community. We work in community settings. We deal with everyday people, people who are among us. But we also,
People. Yeah.
exactly, people. But we also work in long-term care institutions. Part of that because of my personal background, but we truly believe that this population in long-term care facilities is way underserved.
Mm.
And underdiagnosed. And what I'm saying is delirium, which is confusion secondary to something medical, dementias. See, what we usually do, your colleagues and my colleagues included, if we see someone who has cognitive impairment, 50-year-old, 60-year-old, 70-year-old, oh, it's Alzheimer's dementia, which means terminal diagnosis, they're ready to die.
Slap the label on it, adios.
Pretty much. But
yeah,
vascular dementia, as you know, is something that is preventable and can be managed for a long time. We can give people lives if we diagnose them properly and treat them properly for vascular dementia. If we address risk factors, if we treat them properly and aggressively if they're still younger.
Yeah.
So that's pretty much why I'm working in long-term care facilities. We work in memory cares. And another thing, delirium, confusion secondary to something medical. If we are missing the point over here, so people can progress to pretty much death if delirium is not recognized properly and not treated properly.
How is the feedback? I'm sure you've been in this long enough that you've established good relationships with the facilities that you work with, and with that relationship comes an established level of trust. How did you get to that level of coordination, especially with families and the caregivers and the facilities? Because you're working. How can we say this? It's like for us when we work with kiddos, it's like we see the children have an issue, and I've got to go to mom and dad and say, hey, mom and dad, Jimmy's got this issue. This is what we're going to do. But ultimately, mom and dad has the decision to say yes or no about the kid, even though full best intentions. It's just, it's just not going to work. I'm like, well, the kid's going to suffer. I don't know what to tell you. How did you get to that level of trust and authority and coordination within the communities that you're working?
Honestly,
Yeah,
it's very tough in the beginning.
yeah,
And because of we have a huge stigma. We have huge stigma of who is treating what. And we have huge stigma about antipsychotics, which sometimes we have to use. It's a must to manage behaviors. Internet is actually not a good service for us, which I always recommend people, hey, go and look it up. Go look it up diagnosis, which I'm offering you to study and whatever. But I discuss with families. After I discuss with, I mean, nursing home staff is usually
mm,
big proponent of my team.
yeah,
And not only nursing home. I mean, the motto over here for at this hospital was like, Graypel comes and fixes things. And actually, that I was proud of to hear that, but to some degree, actually, it was true statement because we address issues properly, and
yeah.
when the nursing home staff sees patients being more stable,
That's
better.
it. They start seeing results.
Pretty much, they go out and tell families, "Hey, just let him do his thing." You know.
I'm sure at that time you must have got goosebumps. You must have finally, because you love seeing we all love seeing our patients get good results, right? But then again, having somebody else, another medical staff, another medical provider being your advocate and say, just let the man do his job.
Mm-hmm.
Mom's doing better. That's all we can ask for, right? You're getting years back to mom.
Mm-hmm.
Just let the man do his job. And
Yeah,
I'm sure that just there's a certain level of joy that is incalculable that goes to you for that.
satisfies my ego, but but
We
I'm
just
actually
get that,
being
just
treated.
hit that little deflation on the side of your head and just like
Okay.
just let a little air.
Okay.
Yeah, just let a little air out. You'll be all right.
Yeah. But no, it's a serious statement. So yes,
Yeah,
they are big
yeah.
advocate for me because
With advancements in psychiatric treatment, how do you stay updated with the latest developments, and how do you decide which new treatments to incorporate into the practice?
it depends on what treatments we are referring to. We
Sure.
all have to go through continuing education.
Mhm.
I do seminars and whatever. But just like we always have drug reps bringing stuff in, and I'm not talking about drug rep lunches, but new
Right,
information,
right, right.
new information comes, whatever, and they always come in. I usually don't go, honestly. I usually don't go to dinners. Don't have time for that stuff. We have several ways of getting new information in, mainly through my subscription to some continuing education platforms or programs, and they send me just automatic whatever. Plus, I usually go to geriatric symposiums, and even though I'm not geriatrician and not even fellow geriatric psychiatrist, I think I know what I'm doing. I pretend I know what I'm doing, but that's how we get new information. So yeah, we
Good.
try to stay on top.
Good. Just wear the jacket until they tell you otherwise. Be all right. That's right. What future plans or upcoming services can your patients look forward to at the clinic? Is there anything new on the horizon for you that's coming in?
I think I mentioned to you when we met last time.
Hmm.
I just put a website together for cognitive management center.com,
Hmm.
and what I started to do, I started to work with a program that does computerized testing for ADHD, for mild cognitive impairment, for many other things like autism or whatever. So that actually streamlined the whole process. So I don't have to. So I eliminated just the human factor. So I
Mm,
don't have to rely on my rater, how it was rated. I don't have to rely on my personal bias. Well, I'm human. Bias can
right,
be
right, right.
there. This is what I started to do back in August of last year, and it's working very well for me. We've cleaned up a lot of ADHD diagnosis. We actually diagnose people with ADHD who were never diagnosed with ADHD just because of this testing. We've cleaned up some diagnosis and looked into different reasons for anxiety, because ADHD is anxiety spectrum disorder. It's nothing but anxiety, and it's something that leads to OCD or OC personality, obsessive compulsive personality disorder. So that's pretty much what's on horizon for me in my practice. So that's
Nice.
my thing. That's what we are doing right now. Yeah, and I have a couple.
That's got to be so much easier for the public, the community at large. Just be like, I don't need an appointment. I can just do this online. I can get my markers, and then, hey, listen, I do want to get with your team. I do want to get with the staff, and all right, well, let's figure out what the next proper course of action. It lowers that barrier of entry for people.
Yeah.
Just to make things a lot more accessible.
Mm-hmm.
Now, you've authored a book on dementias, adult cognitive impairments. What motivated you to write your book, and how did you envision it assisting non-psychiatrists in understanding these conditions?
Well, the only reason I call it for non-psychiatrists, actually, because we are in a club. You are in a club too, in your club.
Yeah.
So we all like each other to do well, but not better. And I didn't want to kind of to be criticized by my peers. Oh, you forgot to mention this little details, this little detail.
Yeah.
But I actually had two psychiatrists who highly commented on this book. One of them actually wrote a review, and one of them she gave me her mom to treat. So that's stamp of approval. But the reason I started thinking about this book is all my experiences. And that's actually what I started to tell you in the beginning of this conversation. Because my experiences come from internal medicine, long-term care management, and now psychiatry. So I'm unique to some degree. I have knowledge.
No, you're 100% unique. It's beautiful. So it really is.
I have knowledge in all of these things, and my message of this book is, yes, dementia is terminal illness, but before, as we said a couple of minutes ago, before we slap diagnosis of Alzheimer's dementia, let's do our work. Let's see if it's something reversible or potentially reversible. Let's see if we can prevent progression of this disorder, if we can slow progression, or we can at least just keep people alive for a long time. Or if it's, for example, Lewy body dementia, just talk to family and say, hey, look, this is Lewy body dementia. It is what it is. That your loved one will be dead in 3 months.
Yeah.
Like last Thursday, actually, I had in the hospital across the street, I had a college professor, very prominent college professor with Lewy body dementia. And I spoke with his wife, who was also a college professor, and I told her, hey, it's time for us to do hospice. In August, he was perfectly fine. And he was just placed on hospice. He was discharged day before yesterday on hospice, and he's going to be gone in probably a couple of months. But my job was to diagnose them properly and tell them, hey, you need to get your affairs in order now. That's the whole purpose.
It's time, because every day is not only a blessing, but also a day for decline. And that's just the way it is. Yeah. As a clinical associate professor, how do you balance your role as an educator while practicing? And what do you find the most fulfilling about teaching the next generation of professionals?
How do you know this stuff about me? Are you FBI agent or something?
I gotcha, Doc.
No, I have medical students all the time here with me. I'm associate professor at A.T. Steele, which is osteopathic school. But I've done some teaching for University School of Public Health and physician assistants and NPs, and I'm preceptor for Maryville and some other institutions. So yes, I'm always in education, and that's actually another thing that keeps me going and keeps me on my toes and keep me get updated all the time, because I want to be one step above my students and Remember what's the difference of student and instructor, right? They're the same book, just one
Yeah.
baby. So yeah, I just want to be able to teach my students something new and whatever. That's actually how I you know.
And I think there's something to be said for being in practice and teaching instead of just teaching, because there's something to be said for your practical experience, especially as, I will say this, very well-rounded in multiple fields and multiple life experiences that you can't get from a textbook. You can't get from clinical rounds. You have to get yourself, get your hands dirty in order to get that level of life experience. And if it's just not attainable any other way, you've got to dig the hole to appreciate the swimming pool. It's just the way that has to be done.
Absolutely.
Yeah. You know what? I really enjoy this conversation, and it brings me such great joy to see other practitioners actually doing the hard work necessary and going to the root of the problem, not just saying, okay, well, we'll add this, not taking the shortcuts, I think is a fair way to say that, where the new drug rep comes in with the next Prozac, and well, that's what we're just going to give you because that's just what we're going to give you, right? And I think it takes somebody who's done the work and done the effort to actually make bigger differences in people's mental health. And I just want to, from me to you, I want to say thank you for doing that. Oh man, we went through a lot in half an hour. And you're right, I think we could probably spend 3 hours just going through this. It's great.
Talking about myself, of course I can,
Of course, right? Id and ego, right? We'll just feed.
Absolutely. People like me don't have ego problem,
Yeah, yeah, absolutely right. Well, Doc, listen, I want to say thank you for your time today. This truly was lovely. I will put links to your clinic, links to your book, all in this video whenever we produce it, and then as soon as it comes out, I love that we'll stay connected for sure, and let's do some more stuff together in the future.
Absolutely, whatever you can think of for me being involved in community, that's what we do, and I'm more than to participate in whatever.
Good, that's beautiful.
Thank you.
All right, Doc, you're lovely. I'll see you soon. All right, bye-bye.
Bye-bye.